So if you don't mind calling them out, that would be great.
That's fine.
Thank you, Kristen. It's 2 o'clock. I'm going to give it 1 extra minute just for folks to join on. I see several members, but I want to give it a little more time. No, Walter, you look like you're ready for winter. Oh, now you're on mute.
I'm sitting here at work in a dank cabin with no heat.
It's one of those days.
Yep.
Okay.
I've been out in the rain all morning.
Well, stay dry, get some warmth. Okay, so I think we
I
have
will at the meeting, Sue.
great. Thanks, Walter. Um, I think we have a good amount of folks here, and it's just a minute past 2. And we have a really aggressive agenda today, really exciting material that we want to review with all of you, and want to make sure we have time at the beginning of the meeting to do introductions. So that might take a bit of time. So I'll start off today's meeting, and the first thing I want to do is obviously welcome everyone to today's General Advisory Committee meeting of the Green Mountain Care Board. I see we have a few of our board members here today. Board member Merman and board member Holmes are here. Chair Foster is a little bit delayed today, but he will be here very shortly. And we've got some parental leave and some vacations at the board. So, but we do have a strong showing, so I'm excited that they can be here today. We also have a new member of our general advisory who I wanted to call out and introduce, and I'll have them introduce themselves, and then I'd like to go around to the members so that they can hear about you. And what I would like everyone to do is state your name, your profession or the organization you're representing, or if it's an individual representing a consumer, that's great too. And Kristen has offered to call out your name. So I'm going to start with our newest member, Chris Younts, and I hope I pronounced that correctly, Chris. And he is a DS service coordinator from Lamoille Mental Health. So I will turn it over to you, Chris, just to introduce yourself. Tell us who you are. Obviously, I just did that, and a little bit about what you do. And welcome.
Thanks, Susan. Can you hear me okay?
I can. Thanks, Chris.
Perfect. Sometimes the audio issues seem to happen at the last minute, so I just thought I'd check. But thanks, everyone, for having me. Happy to be here. As Susan mentioned, yeah, I work for Lamoille County Mental Health, and we're based out of Morrisville. It's a designated services agency. And I'm in developmental disability services, so working mostly with individuals and their families and teams who have autism spectrum disorder or intellectual disabilities. So that being that folks who meet a Vermont state system of care.
Your call has been forwarded to an automated voice message.
Oops. Sorry about that, Chris.
It's all right. That's okay. Thought it was just me. So yeah, I'm basically a human services provider, and part of that, I have multiple hats. I won't get into all of them right now, but I was referred to this group through the statewide independent living council that I'm also a member of, and I'm the chair of the healthcare committee there. And so we do a bit of work around mostly advocacy around people with disabilities having access to affordable healthcare. And
We didn't get your message either
I'm also
because you were not speaking or because of a bad connection. To disconnect, press 1. To record your message, press 2.
Go ahead,
Um,
Chris.
That's okay. I'm also part of the communication task force, who is also an advocacy group through the state.
Great. Well, welcome. We're really excited to have you here as part of our general advisory. And Kristen, you know, I can go down the list and see. I'm pretty familiar with our general advisory members, but if you could just cross-reference so I don't miss anyone. So I have the first one I see on my list is Elizabeth Hunt. If you could just introduce yourself.
Yeah, hi, thank you, Susan.
Your call has
Um,
been forwarded to an automated.
Go ahead. Sorry about that.
No, that's all good. My name is Liz Hunt. I'm the Director of Finance and Operations at Green Mountain Surgery Center. We're the first multi-specialty independent ASC in the state of Vermont. We do a lot that has to do with just driving low-cost healthcare accessibility to our patients and trying to support all physicians, which we're lucky enough to support both independents and in-network physicians at this point in time. That's pretty much, I'm on a female-only leadership team. So there's 5 of us women that run the entire facility together, which is pretty exciting and different. I'm on this committee just to join in on all of our mission of keeping high quality, low cost healthcare in Vermont because it affects all of us very much. And I have a 17-month-old daughter, another kid on the way. So I have a lot riding on the future of healthcare here. So I'm happy to be part of it. So thank you.
Thank you so much. And the next one I see is Jeffrey McKee. Oops, you're on mute though, Jeff. There you go.
Hi, everybody. So I am the CEO at Community Health Centers here in Chittenden County. We're a federally qualified health center serving about 32 to 35,000 patients every year. Been in healthcare in Vermont for more than 20 some odd years now at the Community Mental Health Center and then at the hospital down in Rutland and then for the last 3 years here at the Community Health Centers. So a lot of interest in how we do healthcare here in Vermont and on this committee to see if I can be helpful in shaping what that's going to look like going forward.
Thank you. You all are very helpful for the record. John Macy, Dr. Macy, I saw you. There you are.
Hi guys, John Macy here. I am a orthopedic surgeon specializing in left shoulders. The Department of Surgery chief at Copley and chief of Mansfield Orthopedics. I've been here at Copley now for about a decade, maybe longer. Worked in South Burlington at UVM for about 15 years prior to that. So I've been around in this area caring for our Vermonters for about 30 years now, since 1992.
Thank you. And I saw Bob Bick join. Bob, we're just introducing ourselves and where we're from for our new members and for Oliver Wyman.
Hi, good afternoon, everybody. I'm Bob Bick. I'm the CEO here at the Howard Center in Burlington. It's a designated agency, the largest in Vermont. And in addition to our mental health and developmental disabilities population, we also have, I think, the largest substance use program for individuals, particularly struggling with opiates. Both in terms of treatment and harm reduction programs. So been on advisory board for quite some time, and will continue for a short period going forward, but looking forward to it actually being in my rearview mirror.
Okay. Thanks, Bob. Thanks for all of your contributions to us. And Walter Carpenter.
Hi, Sue. My name's Walter Carpenter. I work at the Vermont Department of Forest Parks and Recreation. That's where I'm calling in from now, hence the costume. I've been out in the rain all morning. I have been a long-standing member of the Green Mountain Care Board ever since, on the advisory committees, and a groupie of the Care Board since 2011. I was also involved in the creation of the board during the days of Act 48. I've served on a prior authorization subcommittee, probably in around 2015, with Dr. Alan Ramsey, one of the first members of the board, presiding over it. I've been a longtime single payer advocate ever since I almost died at the hands of private insurance. And when I come to these meetings and speak, I do so as a patient and as a taxpayer and as a ratepayer.
Thank you. Oh, Walter, are you done?
But I've been a groupie of the board, and this is my third advisory committee I've been on with the board.
Well, thank you, Walter, for all of your help and your service to us and to Vermonters. We appreciate it. And stay warm. I see, try to stay
I'm
warm.
used to it, Susan.
Okay. I see Sharon Gutwin has joined. Sharon?
Hi, I graduated from UVM in physical therapy back in '79, and my first employer was then the hospital, two parts, Mary Fletcher and DeGosbriand. And at that time, there were no other choices in physical therapy. There were no other outpatient PT clinics, and I helped my friend launch the first private PT business in Vermont. I have worked in many departments, every department within the hospital and in outpatient, and came from the sports and orthopedic rehab center associated with the ortho doctors that are now at Tilly. And then Fletcher Allen, it was called, took over SORC by a hostile takeover. It launched 5 independent PT practices, and mine is one. So the rehab gym has been in operation since 2003, 3 locations.
Wonderful. Thank you, Sharon. And let me know if there's any other advisory member I missed. I don't see one, but please chime in right now if I did miss you, and I apologize if I did. Okay, great. Couple of other things. I just want to call out our federal partners who I see on the line. So Beth Stern from Senator Sanders' office is here. So thank you for joining us, Beth. And Ina Backus from Senator Welch's office is joining us. So we really appreciate you taking time to listen in today. And I think that you'll, as all of us, will be really informed by this community engagement plan that we're launching. The other quick announcement that I have is that we have a few new staff members here at the board, and I just wanted to call them out. We have Micah Morton, who is a new data analyst with us. We have Angela Pellegrino Wood, who is a new health policy analyst. And last but certainly not least is Elena Barabee, who is our new director of health systems finance. Sarah Lindbergh, a longtime state employee, has moved on to a private sector role, and we were very lucky to have Elena step up into her role on the directing the finance team. So those wanted to just update the GAC on that. And then the last thing I'll say, and then I'll turn it over to Marissa Melamed, is we've had a very busy summer, and back in the spring, we received rates for individual and small group and individual markets. We reviewed those rates over the summer and decided them in August. The results are on our website, and we did share a press release with all of you to remind you of where we landed with that. And then just on Friday, we finished up the voting on the hospital budgets, the 14 hospital budgets. Those orders will be written over the next 2 weeks and delivered to the hospitals on October 1st. So with that, I am going to turn it over to Marissa Melamed, who is Associate Director of Health Policy at the Green Mountain Care Board. And she's going to give you a little bit of background on Act 167 of 2022 and how we got here, and then turn it over to the folks from Oliver Wyman. So take it away, Marissa. Except you're on mute. Better.
Can you all hear me now?
Yes.
There was the double mute, the system mute and the phone mute. So thank you, Susan. I'm really happy to be here with you all today to introduce the Act 167 community engagement process and our team at Oliver Wyman. Before I say a couple of words, I realized, Kristen, I didn't check with you or Chidera. I'm not sure who is planning to share the slides, but you could get those up now while I do the introductions.
Sounds
I think
good.
maybe it was Chidera, but you got it.
Yeah, I'll share the slides.
Okay, cool. Thank you. So again, my name is Marissa Melamed. I am the Associate Director of Health Systems Policy at the Green Mountain Care Board. I've worked at the Green Mountain Care Board for, I think, over 8 years now. And this, I've worn many hats at the board, working on almost all of the regulatory processes and other special legislative projects that the board has been involved in. Most recently, I oversaw the ACO oversight program at the board for several years, but I've recently moved into the new role as a project director for the Act 167 community engagement work specifically. So I'm really excited to be involved in this project. I'm joined by Hillary Watson, who, if she's able, can pop on camera for a minute so you can see who she is. She's a health policy analyst with the Green Mountain Care Board, been with us for just 6 months now, and is very ably also helping us with this project. And I'm sorry, I can't see if you did pop on or not, Hillary, but if you want to introduce yourself any further, you can.
Great. I'll just say hello. Hillary Watson, as Marissa shared, and just really grateful to be here with you all. So thank you.
So if there are any follow-up questions of any kind, or you want to direct people toward this work, Hillary and I are the staff team leading the work for the board. So please do not hesitate to reach out to us with any questions. And you can go to the next slide, Chidera. So just for a little bit of background, I'm not sure, how much history everyone in this group has. So I'm going to go through a little bit of it with you now. There's a lot more information on our website. But this work, this community engagement work is several years in the making. Big picture, it's the board's work to regulate hospitals that has brought this to the forefront for us. A little bit of background, I'll go back to 2019 with the Rural Health Services Task Force that had the purpose to evaluate the current state of rural healthcare in Vermont and identify ways to sustain the system and to ensure it provides access to affordable, high-quality healthcare services. That task force had 14 members. It was designated in statute and met throughout the second half of 2019, and it brought together a group of people to think hard about the future of Vermont's rural healthcare system and how to ensure that all Vermonters can access high-quality, affordable healthcare. That same year, the Green Mountain Care Board also required a subset of hospitals to develop sustainability plans due to persistently low and declining margins and the news that Springfield Hospital would enter bankruptcy. So that really brought this issue to the forefront. In 2020, the board expanded the requirement for hospitals to develop sustainability plans due to the impacts of the COVID-19 pandemic. And in part, as building on the Rural Health Services Task Force, the legislature passed Act 159 in 2020, which required work on two major reports, including options for regulating provider reimbursement. That report was released in early 21, and the Hospital Sustainability Report, which was released early 22. And then in 2021, a lot of work went into developing that Hospital Sustainability Report, including analysis and stakeholder engagement, noting that many provider partners were focused on the COVID-19 response at that time. In 2022, the Hospital Sustainability Report was released with hospital global payments as one major recommendation, in part growing out of legislative discussion around the findings and recommendations from this report. The legislature passed Act 167, which included work on the next iteration of the all-payer model, agreement with the federal government, global budget payment model, regulatory redesign, and community and provider engagement to inform hospital transformation, which is what we're going to focus on today. These recommendations were echoed by legislative consultants who recommended pursuing global payments as well. And Act 167 provided the Green Mountain Care Board with over $4 million in dedicated funding for these activities. So it's a huge part of the board's work. I think that's probably enough background on this slide. You can go to the next slide, please. So just to visualize here, so the four work streams of Act 167, sections 1 and 2. There's the subsequent all-payer model agreement, which that work is led by the Agency of Human Services in collaboration with the Green Mountain Care Board. Developing value-based payment models. So hospital global budget development is led by the Green Mountain Care Board in collaboration with AHS. And that work is led by staff, by Sarah Kinsler and team at the board. So different bucket of work than we're talking about today, but out of the same legislation. Also, there is work on evolving the Green Mountain Care Board regulatory processes, specifically around hospital budget review. And Elena Barabee is leading that work for the board. And then finally, the community engagement to support hospital transformation, which is led by the board with me as the project director and in collaboration with partners at AHS. So what we're really going to focus on today is that fourth bucket and sort of where we are in the process now that we've gotten to a place where we're ready to bring it to the public. So you can go to the next slide. So where we are now, the Green Mountain Care Board has retained an expert to support a data-informed, patient-focused, community-inclusive engagement process for Vermont's hospitals. That contract team is Oliver Lyman, who we have the team here with you today, and I will turn it over to them shortly to introduce themselves. They will, in a sort of broad sense or in a nutshell, they'll review data and solicit local input to develop options that ensure Vermonters have sustained access to affordable care. They'll be working directly with community members, businesses, hospitals, and healthcare organizations to ensure a wide range of voices are represented in these discussions. And we also have contractor support from an amendment with an existing contractor, Mathematica Policy Research, to provide data analytics support. And information about this process, postings of meetings and information and such going forward is posted on our website at this link, the Green Mountain Care Board Community Engagement to Support Hospital Transformation. So with that, I think that's enough of an introduction to turn it over to the Oliver Wyman team. They're going to give you an overview of the project and the stakeholder engagement, the statewide stakeholder engagement plan that they have, and solicit some feedback from you all. So this is not just, they're not just going to talk at you. They're going to welcome participation and questions and such as we shape this process. So I'll turn it over to Bruce. Thanks.
Great, thank you. And thank you all for giving us the opportunity to show you the plan, and most importantly, to get your feedback on parts of this. We need to be respectful of time. We have about 35 minutes, and I'd like to take the first 12 to 15 just to go through this, and then we'll come back to some specific slides and ask really for your input. At the end of this presentation, there are going to be some links to our email addresses. And one of the very particular things that we would like to ask this group to do is to give us the names of some individuals and organizations in some of these different areas that we could directly contact to get feedback. And we'll show you how we're planning to do that. My name is Bruce Hamre. I'm a physician, spent over 20 years in academic medicine, practicing teaching, have spent approximately 20 years in medical administration, university hospital, and a large teaching hospital as the director, and about 10 years now in healthcare consulting with Oliver Wyman. So one of my compatriots here is Ms. Elizabeth Sutherland. She is an expert in diversity in healthcare and the disadvantaged, and in fact led or strongly supported the Pennsylvania governor's initiative on providing health care. Dr. Chidera Choueki is a new, relatively new addition, been with Oliver Wyman a couple of years. He trained as a neuroscientist, but he's the project manager and heavily involved with Marissa and Hillary in getting this project going. Next slide, Chidera. Okay, so the things that we specifically would like your input on are looking at the main engagement components, the models, a little bit about the interview content. That's explained in a high level here. We want you to think with us about the evaluation of potential solutions. We're just going to start that process. We don't have time to go into that in a lot of detail, as you'll see. As I mentioned, we'd like to get contacts for providers and community groups, community leaders at the HSA level, if they come to mind, and obviously try to do that at the end of the meeting. And then any specific questions that you think we should ask of the various stakeholder groups. Next slide. So we've done the overview. We're going to show you the engagement plan and the interview plan, and then we'll move on to the model, the engagement model, and the solution evaluation. Next slide, Chidera. Okay, this shows you the overview of timing. We are almost complete with step one. This was the first 4 weeks where we really refined the details of the plan and have given that to the Green Mountain Oversight Group They've provided feedback. We're adjusting that now. We'll get that settled this week. The step that we are embarking on, and we've only had 2 meetings thus far. You'll be the third. One was with a group of provider organizations. The last was with the Secretary of the Department of the Agency of Human Services, rather. And what we're intending to do with this step is to develop an understanding of where things are. We've reviewed a lot of data, which is public, and a little bit that's unique to the state, reviewed data by other consultants, so that we have a baseline understanding that now we need to vet first with the hospitals and then to gain additional insight from a variety of the stakeholder groups. We'll show you who those are in a minute. The step toward the end of this first period, step 3, is to begin to formulate solutions to these issues that are identified. Have Mathematica do some of the detailed analyses of what the outcomes could be, and then vet those with the Green Mountain Care Board Oversight Group, and then take those back to the hospital groups, hospital boards in the individual HSAs and the communities to present that set for feedback. So it's a real feedback loop here that will encompass a large number of stakeholder groups providing input at the start, but then a vetting process and a final feedback process for the communities at large and the hospital groups who are going to be the most affected here. Next slide. Okay, so this shows the timeline, and the point in the green is here's where we are. This dark area in the middle is in effect a winter break at the advice of the Green Mountain folk. Winter is hard to travel, and we are going to do the second round where we share what the potential solutions are in person. The first round will be virtual, but second round we're going to be going. I live in central Massachusetts, so not far away from you. We're going to be up to physically be present with the hospital leadership and board and with the community. And so the timing here is due to 2 things. One is travel. The other is that this is the time when the Mathematica people will be doing the more detailed analyses. So we anticipate getting back up in March, and then completing that process, the 14 HSAs, getting a report into the Green Mountain Board sometime in May. Next slide. This shows where we are in terms of developing the current state understanding and the first round listening sessions. We are going currently through the state level discussions with the provider groups. We've had one. We have not yet started the diverse populations. We need some of your input on that. The community leaders, we are beginning to schedule meetings with, and would also look to their leadership and their advice on identifying community leaders at an HSA level. We have a meeting scheduled later this week with the appropriate legislators in both the House and Senate. We have started a state partner discussion with the Secretary, and we'll continue that with some individual state agencies. And then healthcare related organizations such as this group. We are scheduling HSA level discussions. The green triangles show you who we've got so far. We have 6 scheduled. We got a response from a 7th this morning that we'll schedule, and we still have a few that we haven't heard from. So if your HSA is not on this list, feel free to contact your local hospital and ask them to meet with us, because their feedback is key. One of the things that we want to do with the hospitals is confirm with them the data that's going to be used for the analyses. For example, we're very well aware that some of the previous analyses used licensed hospital beds rather than those that were staffed by nurses and available for patient care. So that's one specific area. And there are a number of others that we want to ask about in terms of difficulties in getting patients in and out of the hospital, in and out of the emergency room, and so forth. Next slide. Okay, so this one we need some help on. We'll come back to. Note that the various stakeholder groups and large groupings that we've identified are the hospital leaders and the boards of directors of the hospitals. We are contacting the care under providers, professionals, and statewide associations, as well as certainly the larger groups of group practices providers of care. For example, the federally qualified healthcare centers. Diverse populations, Ms. Sutherland is going to go into more detail with you in just a moment. Community leaders I've commented on. We will schedule sessions for general community members, patients, families, taxpayers, other important people. State of Vermont partners, we've mentioned, legislators mentioned, other healthcare related organizations. And most of this is to find out how they relate to the hospitals. I mean, this project is focused on sustainability of hospitals, but how they swim in the healthcare ecosystem that they live in locally will be key to that. And then last, we will meet with some of the payers to get their opinions, and some of the people who purchase healthcare insurance, people who buy small group insurance, and some, I'm sure, individual purchasers. So we're going to go through now in detail on the diverse groups and the disadvantaged. Are there any comments or input that anyone on the call would like to give? Any of the members? Okay, next slide, Shadira. Elizabeth, I think this is yours.
Yep. Hi, everyone. Thanks, Bruce. And so as Bruce mentioned, part of the goal of our efforts here as we think about potential recommendations to improve healthcare delivery, hospital services delivery in Vermont, is to ensure that we're focusing on those that are have either been disadvantaged or have a smaller representation across the state, to understand the current state of that, of the disparities, as well as what resources are available. This isn't, our goal isn't, before I get into the left side here, our goal isn't to come up with a health equity strategy. There's a lot of work already underway within the state to do this, but to really understand what resources are available, where are they, what would the potential impacts be from some recommendations, and that we're communicating that across all avenues, and then also getting input from these groups as stakeholders to the process. And so starting with the groups as stakeholders to the process, we're sort of centering on the groups you see to the left here, which is driven by the population served by organizations receiving health equity grants within Vermont. And so noting that this is not a mutually exclusive list that adds up to 100% when you get to the total at Vermont, there's a lot of intersectionality here. But the way in which we will start gathering information and pulling it together to understand current state is around our BIPOC communities, immigrant and refugee communities, LGBTQ, IA+, low to mid SES, so socioeconomic status. So that's not just those in poverty, but also looking at working poor. Shared medical conditions, which is really great to see within Vermont that there is quite a bit of community around shared medical conditions already. And so leveraging the channels that exist, great to already hear about those focus on autism earlier. And then, but also we've seen disabled, neurodivergent, mentioned psychiatric recovery, AIDS, HIV, Hep C, substance abuse. And so looking to make sure we're getting input from those groups. Then also just looking into additional disadvantaged populations. So knowing that the rurality of Vermont is very high, we want to tap into the task force that are looking at outreaches and interventions there, as well as looking at the veteran population, unhoused, which we know has gone up quite a bit in Vermont over the past 3 years, most acutely. Our seniors, particularly as being an older state, understanding what resources are available and where there are gaps, looking into isolated, then also the incarcerated population. As I mentioned, this is more to just kind of gather understanding of where the current state known gaps are and what resources exist. I will pause before I get into the engagement model to the right, but is there any glaring missing groups that are outlined that seem to be missed from the left side of this?
And I'll just say, because we do have quite a robust list of folks who are not on the general advisory, if while you're here, I mean, either you can share it today, or if you want to email the OW team, that would be great. But sorry to interrupt there. Thank you.
No worries. Thank you. Please, yeah, if you'd rather send feedback outside of the group, please do. Yes, I see David, hands up.
Hi, yeah, just I think this is a very inclusive list and super helpful to consider all these. The one additional one I was just, and I don't know quite how to capture it, is people without transportation, without a car.
Yep.
It is very impactful. But I work as an emergency physician, and the thought of a isolated, rural, elderly, senior vet hits 4 of those, and if they don't have a car, it's really, really, really challenging to get healthcare. Thanks.
Absolutely. Thank you thanks for bringing that in. A little bit of context to just kind of the way in which thinking about we're really focused on medical access and outcomes, and access is a huge point there, right? So when we see where there's difference in kind of your access performance rates against these groups, that's where the root cause will come out as transportation. And so that will be something that we want to make sure we're looking at in terms of rurality, all those groups that you just listed, but what are some of the ways in which we can be kind of addressing ensuring that we're not getting in the way of some of those solutions that are the root cause for many of these populations, one of which is transportation. Thank you so much for saying that. Dr. McKee.
Yeah, I just thought going back a slide and trying to align this, whether this was a statewide level or an HSA level kind of analysis within these groups. I couldn't do, I wasn't sure. But just to say that across the state, different areas of the state look very different with respect to the challenges and access issues that any of these groups might have. And to keep that, I think it is an HSA level conversation, not a state level conversation.
Great point. And so some of this, as you might imagine, the data is when we look at the data perspective, some of it's available at that level, some of it isn't. Ideally, we look at statewide just to help us get an idea of how we look to other states and how we look and comparing against these populations across the state. Then we look within the HSA, and we're really going to be getting at this locally where we can. But there are some groups that are only kind of where we are able to get this information from the state's perspective. And so best case scenario is understanding at the HSA level, but we're going to be guided by some of the information that we already have that might not be that specific.
But we will be analyzing the impacts of any changes in hospitals on these populations and addressing with the hospitals and other the not-for-profit organizations, service organizations in each SA, how these needs are being addressed. So to your point, absolutely understand a great diversity among the hospitals and their related communities. Sir.
Sam.
Hi, sorry, it took me a second to come off mute. Sam Paish, I'm at the Office of the Healthcare Advocate. Thank you so much for this presentation. I just had a question related to language access and language justice, particularly for the immigrant or refugee community. Mike Fisher, the Healthcare Advocate, and I, we serve on the State Health Assessment in the steering committee. And this is also talked about there because they're doing a number of assessments across the state. So I'm just curious. I mean, I might have missed it, so I apologize if you talked about this already. I'm just curious how you plan to address that.
Plan to address language.
Yeah, like
language.
folks that for whom, that language isn't a primary.
Yeah.
For them, yeah. Yep.
Yep. So as part of the, we'll get into a couple KPIs that we're looking at, but some of them which will fall out through this is around care teams looking like and interacting with the patients in a way that makes them feel seen and heard. One of which will come out of that is absolutely language. Is that, while we're here, is that a known gap right now? Is that there are some language services that are not available?
Yes, I would say so.
Okay, thank you.
Thank you, appreciate it.
Very important. And I think Walter, next.
I was just curious, when you study rural populations about this, have you ever lived in a rural environment?
That is a great question.
Really rural.
I have not myself.
I'll comment. I have, and actually do now, and ran a large health system in north central Pennsylvania, where the major industry was forestry. Lived in a town of less than 5,000 people there, and I'm on the board of a small hospital in Bozeman, Montana, 125 beds, with a critical access hospital. So, and we have, in my part of Massachusetts, we have town meetings. So somewhat familiar, I'm sure not familiar with rural Vermont, but certainly small towns, small practices, small hospitals in very rural areas.
Because they
Walter,
do
I'm
think
curious.
differently.
Yeah. Did you have anything else on that, Walter, or just to
No,
make sure we know
that's
that they
it.
think
Yeah.
differently? Okay. Fully understood.
trying to get
And to answer your question, I live in central Pennsylvania now. And so not fully rural, but similar to Bruce, like understand they think differently. And that's why we're soliciting as much input as we can, right? To make sure that we're considering all aspects. Okay. In terms of the interaction model, I think we hit a bunch of them, but the idea is that we do want to get down to understanding current state and current resources for these groups at the local level. We will be working with statewide agencies to understand some of that to begin with, and then we'll be asking questions within HSA discussions around these specific populations as well. So what we're in the middle of working through how the right organizations to help us get the best current state understanding of what's already been done. I think Bruce might have said this, but we're not trying to re-complete a community health needs assessment. This is to build on top of what's already known and to really ensure that we're taking into consideration the impact of recommendations to these populations as we go through this process. Right. We'll dive deeper into the KPIs for these and other populations we're looking at. I think we're going to show you a quick view of what the content is for the discussions that we plan to have at the HSA level. So I'll turn it back over to Bruce for that.
Okay, thank you. So we're going to use a standard presentation. You've experienced a part of it with each group to review simply what we're trying to do and that we're here to listen. So for us, it's a learning exercise. One of the things that we expect from the various populations and groups is, are there specific questions they think we should be asking? Right? I mean, we're not really coming at this totally as the experts. You know, we've done a lot of work. I've done a lot of work redesigning health systems, including for a couple of countries. And the health system I ran is larger than the state of Vermont and the population. So, but this is a learning exercise for us. And we want to get the stakeholder perspective, the bottom bullet on this overview and objectives. We really want to get people's perspectives. What issues are they facing? What potential solutions are there that they think might be possible? What do they see happening in the future? We'll introduce the team. We'll provide an overview of the process, mainly the timeline. I mean, we're trying to give people the understanding that we have a limited time. We're going to do the bulk of the time getting the first round assessments, but we will be back in the spring to present solutions, both statewide and at HSA level solutions. Although the HSA level solutions pretty much to the hospitals, because they're the ones that are going to be mainly affected there. We'll, in these interviews, these listening sessions with the hospitals, we're going to review available data. As I mentioned at the start, hospitals have said that some of the data they don't think is correct or correct in their instance. We want to find out what their delivery status is. We've done, Elizabeth and I, a lot of work in hospital operations, how you make them more efficient, how you get people in a timely way, how you improve your quality, how you improve equity, and so forth. So we're going to center on those discussions, find out how the hospital is approaching and assisting its community in becoming healthier, and try to identify with the hospital, particularly the leadership and the board, where they think things are going. You have a lot of moving pieces in Vermont. You're looking at changing the way hospitals are paid to a global budget. Federal government is moving more and more Medicare beneficiaries into managed care programs, Medicare Advantage. You have a big ACO program in the state, and we really want to understand how the hospitals are viewing those impacts on their sustainability and survivability. And then we'll basically share the rest of the process, the timing and what the outputs will be. Next slide. Okay, so here's what we're going to do with each group. The HSA characteristics, we will present, we will get perspective on from the various people in those HSAs and in the state. We will want to vet the data with the hospital leaders. Do we understand you correctly and your services and why people aren't availing them of your services or that sort of thing? We will then go to the current delivery status of the hospital. You know, is the data correct? What kinds of hospital redesign efforts? What are you thinking about in terms of controlling costs? What are you thinking about in terms of changing your services or the way they're delivered? Have you thought about other cost control measures? A couple of hospitals, for example, are thinking about sharing laundry services. And, you know, when I ran a big system in Pennsylvania, our whole region, our system, a bunch of others had a shared laundry service. It kept costs down quite a bit. So we want to also then get input from the community, the blue checks, as to what they might be considering or thinking about. Want to talk then over about community needs. What services are available? Can they be accessed in a timely way? We did a study with the Green Mountain Board through the Department of Finance on accessibility and timeliness of access to care about a year and a half ago, resulted in a report, showed a lot of issues, many of them related to a shortage of people able to provide that care, particularly specialty care. So we want to get more current data and more current views on that. And then the last point is, where do you want to go? What's the optimal place that the community, the people, the hospital would like to wind up in? And obviously it's not building an open heart program in every hospital, but there are certain services that most communities are going to feel they really need to have. So that's the way we're approaching the listening sessions and the more direct interviews. You'll note that we do want to get feedback on available information and get additional information on accessibility and service levels and service quality from the diverse groups, the community leaders, and the general community. And so, as was mentioned earlier, some of that is, are the people providing care able to speak your language, or are those services available? Are they sensitive to your cultural and personal preferences? Do they take those into account when you receive care? Next slide. I'll stop there for a minute. Are there questions or comments about this approach? Yes, sir.
Hi, this is John Macy here. I'm a physician, and I'm just wondering, how are you planning on marketing this to get community members engaged and involved? You have access to leaders and providers and other professional groups, but getting access to community members, I think, is going to be key. And my one suggestion is to potentially ask providers that see these patients to identify patients that may want to be part of this process.
Right. Thank you. Excellent suggestion. There are a couple of ways we've thought about this. One, the Green Mountain Care Board has a website, which a
Patients
number of
don't
people
access the Green Mountain Care Board website.
I know. So let me keep going. Haven't finished. I think your suggestion is a key one. We've also intend to ask the hospitals to give us some contacts and to provide information about the availability of these virtual sessions in their publications, and to help us contact the local media, the newspaper, the radio station, so that we can make this broadly available. Because, frankly, sending out 1,000 emails will be somewhat difficult, possible, but somewhat difficult. But do agree, that's part of the reason we're having this conversation with you all. Yes, sir, please. Does that answer your question?
Yeah, thank you.
Okay. Thank you for that. Other questions or comments on this plan, this part of the plan? Okay, next slide. We're getting some discussion here. Okay, and so this green part is what I mentioned, right? This is to follow. The developed recommendations will really begin in November, late October, November, based on feedback to that point, be able to formulate the questions to ask Mathematica to evaluate, and then we'll put all that together as we reconvene in the spring. Next paragraph, or next slide. Okay, so this shows the various things we're trying to that we will be looking at in terms of the current services. And then in the middle here, how they impact the goals outlined in Act 167, efficiency, decreasing costs, or at least stabilizing costs, going to be hard to perhaps decrease, improving population health outcomes, reducing healthcare inequities, increase access to essential services, and then trying to maintain emergency management capacity for things like COVID. Now, a little background here. I'm an ID guy and was involved in a fair amount of that, including some at Vermont, and how you responded to that stress. The key performance indicators, these have suggested, they have not yet been vetted or approved by the Green Mountain folk. And we would certainly welcome your comments on these. These really look at available data that most of which is already collected by the state. I would simply note, if you look at population health outcomes, about the middle, you see cancer incidence. We do not anticipate we're going to affect the rates of cancer, but hopefully can affect the stage at which it's diagnosed. Same thing for lung disease. I will stop there and ask, well, one of you gentlemen, I can't see names yet, to comment, please. Mr. Macy.
Yeah, Dr. Macy, were you, did you have another question?
No, sorry.
Okay.
I don't know how to.
Great. And
Okay.
as Dr. Macy is putting down his hand, one other thing I wanted to say is the Front Porch Forum is also a really great resource.
thank you.
Folks in Vermont are pretty familiar with it, or a listserv, things like that. But thanks for your comment, Dr. Macy.
Yep.
I
Thank you.
see,
We'll add that.
Great. Great. I see Dr.
Dr.
McKee.
McKee.
Yeah, I think the KPIs that you have here are a great starting point. And I'm wondering how you would perhaps use these KPIs at the front end of the process to identify priority areas as well, rather than just kind of using them as presuming it, and the way you presented it here, that all of these things should somehow be changed. Perhaps we're leading the country in some of these areas. Perhaps we're significantly lacking in some of these areas. Will you use these data to help set priorities within the system design?
Yes, thank you. Most of these have available data, because one of the requirements for these is that the Green Mountain Board be able to monitor changes in these over time as whatever suggestions are made are implemented, so that we see, in as much real time as you can get, what the effect of suggested changes on the hospitals and delivery systems is. And certainly one of the things that we would appreciate your and others' feedback on are the key performance indicators for mental health. Okay, these are pretty crude. And I don't really know, the suicide rates from the vital record statistics. Attempted self-harm is going to have to come from the emergency rooms and providers, but there may be others that I'm an infectious disease guy, not a mental health specialist. So if there are suggestions on that, we'd love to have them.
Well, certainly that's a particularly tricky one, but I guess my question was really more about how to use any of these metrics to inform how the system should be reformed, right? Or how the design should look different. We could theoretically, if we only look at these indicators after some design plan has been put in place, we may not be changing the correct things, right? So wouldn't this analysis really be on the front end before you even initiate a plan?
Yes.
Yes, it will be. And that's strongly anticipated. For example, readmission rates, well known, ways to decrease those, well known. Same thing with in-hospital mortality. Same thing with 30-day revisits to the ED. I mean, there's a lot of experience, and I've got a bunch of it because we did a
Yep.
lot of this at Geisinger, on ways to affect these, and those will be drivers of the recommended or the suggested changes.
Thank
Does
you.
that help?
Yes, it does. Thank you.
Thank you. No, thanks for clarifying. Dr. Merman. Oh, you still have a hand up. Okay.
I apologize.
That's all right. Next slide, Shadera.
Sorry,
Hey.
Bruce, there were a couple of other hands up.
Oh, I'm sorry.
I can help with the hands. How's
Yeah,
that?
if you,
I
yeah, if
see,
you'll handle that, and we're
Right, I
gonna,
see the next hand is Chris Younts.
Hi, yeah, thank you. I just a potential solution to consider came to mind when it came to the mental health piece in terms of improving outcomes. I'm curious if Bruce or anyone else here presenting this today has considered or has heard of the Institute of HeartMath.
I have,
I'm assuming no.
yeah, I
Yeah,
have not,
great.
but be willing to learn.
Yep.
Yeah. I mention it here because it's super relevant to this. It's an institute of research out in California primarily, and I'm actually a certified trained HeartMath instructor, so I have quite a bit of knowledge in that particular realm of research that was essentially backed by my agency, our designated agency providing human services and developmental disability services in terms of improving mental health, emotional health, those types of things. And it's all based on research on the connection or the relationship between the heart and the brain, kind of like paradigm shifting research that's sort of it's evidence-based science. So it's not like woo-woo stuff. It's like all strictly based in science around coherence specifically. So it's all about synchronization of the heart and the brain. And so there's a lot there, I think, to unpack more than we have time for, but just something to consider, I think.
Thank you. I'm going to read up on this and I'll send you questions since I know it's based on.
Yeah, if you could send us a link to that.
I'm looking at it, Bruce. I'll send it around. It's fascinating.
Okay, perfect. Thanks.
Yeah.
Great.
Other
Thanks.
For sure. And I hold monthly, no problem. I hold monthly workshops on this too at our agency. So I'm happy anyone is super welcome to come to them. Just let me know if you're interested.
Thanks, Chris. We'll share it out with the advisory as well. Thank you. Dr. Macy. Tom Macy.
Yeah, I just had a quick question about the community increased access to essential services. How do you collect the access to care data? Is that like waiting times to get in to see a primary care or a specialist, or where does your data come from for that?
Well, initially, I mean, that's the hospitals report that to Green Mountain Board. That's one of the things that they report in their annual requests for the rate increases.
Sure. So that's the problem I see, is that you're not looking at the primary care providers' offices, and trying to get into a primary care office is nearly impossible in Vermont. If you're a new patient trying to find a new provider, it's nearly impossible. And many of these physicians do not work in a hospital.
Yep. Well, do you have a suggestion as to how we might get that? We are going to be asking the communities about how easy it is, but not, we won't have a time component, certainly.
Well, that was where I was getting at with really getting access to community members to poll them.
Well, that's what we're going to do, right? We'll have the community meetings, and that's one of the questions.
I think asking some of the organizations, like maybe the Vermont Medical Society or other professional organizational societies, may have better handling on actual numbers.
Great, thank you. Also planned for some of them, not all.
Just a quick comment on that. This is Dave Merman on the board. I think I saw earlier that you are involving bi-state primary care in early
Yes.
conversations, and I think they would be helpful in a lot of that as well.
Right, and the AHEX, I mean, will be another group.
This is Jessica Holmes. I just want to add that the Agency of Human Services did a wait times survey among Blueprint practices. I believe it was in the late fall. So that's also another source of data. We have to get that data, but it's being pulled together.
Right. Okay.
I do see
any
another
other-
hand up. Sorry, Dr. McKee.
Yeah, I think you mostly covered it. It was just that data for the F2HCs, at least, we could give you very comparable data to what the hospitals provide through bi-state. But those other sources are terrific as well. But there's other, not just primary care, there's other kinds of, healthcare providers in the community who may have similar statistics, and to have a case being made by a hospital that the data was showing that their wait times were very long and therefore they needed to create more capacity would lead us down a wrong path, I think.
Right, thank you. Next slide, Shadera. Okay, Elizabeth.
Right, and so this is just a little bit more, there's a couple out of the areas that we already discussed in sort of the KPIs, there are some places that we're going to want to dive in a little bit deeper to, as we think about the impact on the diverse populations. And so those are in the blue text to the blue box, white text over to the right, and just looking into what do we know about healthcare workforce representing diversity in populations they serve. The populations feel seen and heard by healthcare workforce. There's access to physical activity, and also access to healthy food. We're also looking at population-specific community programs. As I mentioned before, we're not trying to reinvent some of the wheels here. We're trying to understand what's already there to identify if there's any efficiencies that we can note from redundancy around either best practices or even combination of services. And then also to ensure that if there's any impact to some of these programs through our recommendations, we're noting that and addressing that. Again, this will be, to reemphasize, this will be prior to recommending and then looking at the impacts of these afterwards. So doing the current state against these KPIs, and then we'll project impacts to these KPIs after based on recommendations.
Right.
I see some questions.
And this includes transportation. It will also include access to broadband internet. Which, as you also understand, is an issue of inequity and important to the way healthcare is moving, perhaps.
Yeah, I do see a question. Is that okay, Bruce and Elizabeth?
Please.
Susan Aronoff, go ahead.
Hi, folks. I'm Susan Aronoff. I'm not technically on this advisory group, so thank you for giving me a moment. I do policy work for the Vermont Developmental Disability Council, and
Right.
I would like you folks to know that Vermont's Department of Health has an entire office devoted to the health disparities in Vermont.
Mm-hmm.
They've done a lot of research already. The largest health disparity group is people with disabilities, but they've got data information on the health disparities, the way that impacts 4 different populations: low income Vermonters, Black Vermonters, I don't really like BIPOC, but the group you're using is BIPOC, and LGBTQ Vermonters and Vermonters with disabilities. I would really encourage you to reach out, because what you have here, I'd hate to see you spend this precious opportunity reinventing work that's already been done that could be taken to another level. So
no, thank you for that. We that was one of the reasons we met with the Secretary of AHS last Friday, was to get access to these folk, because you're exactly right. We do not intend to redo anything that's done, and we appreciate you bringing that back to our attention. Thank you.
Susan, can you give me the name of that, though? I want to make sure that I do have that report. Is there a specific agency
I
that
couldn't
is,
find a chat. Yeah, so it's the Vermont Department of Health. And they have an office on health equity. And I'll
Yeah.
send it to Susan Barrett.
okay,
How about?
thank you. Thank you. Just wanted to make sure. There's a lot of equity and stuff in Vermont, which is good. And definitely don't want to reinvent the wheel. So I do want to make sure I've got all of it. So thank you so much. Yeah.
Right, you're absolutely right. There's also this health disparity, like Health Equity Advisory Commission that my boss is on, that was created by the legislature. That's another group to touch base with, but they're not doing the research. They're trying to come up with how maybe there'll be an Office of Health Equity going forward. But what I was referring to is specific research already conducted, and I'll send the link to Susan Barrett.
Thank you.
Dr. Macy.
Sorry, along those lines of redundancy, you meant, Elizabeth, I think you mentioned this earlier, but the community needs assessment, which is done every
Yes.
other year or something.
Yep,
You know, I mean,
yep,
that's
yep.
got to be a huge treasure trove of information that I'm hoping you're considering.
Yeah, we've
Absolutely.
reviewed all that. Thank you.
Thank you.
Absolutely. And that's one of the things we'll go over with the hospitals are their top 3 to 5 priorities and what's going on with those. But thank you.
Do you have another question, Dr. Macy? Okay.
No, I'm trying to lower my hand. I can't tell if it's lowered
It's
or
okay.
raised.
You're good. It's low. All right.
Okay, next slide, Shadera. Okay, so, basically this summarizes the process, right? And the roles of the groups. We will make based on the analytics from Mathematica and our initial listening sessions now through mid-November, we will put a number of recommendations together at an HSA and a state level to present to the Green Mountain Care Oversight Group. Prioritize those recommendations against some of these key value drivers that we've shared with you, and then take those to hospital leaders to say, okay, how does this affect you? Does it help keep you financially sustainable? What does your hospital look like in 5 years? Or what does your healthcare delivery in your area look like in 5 years? How does that affect community health? We'll come back to the general populations, being sure we include the diverse populations as well as the general community. Again, this is face to face, so there'll be a general meeting, well publicized in advance. We're going to try to get these scheduled in mid-November for the spring, so that we can get sufficient communication out repetitively to the areas to let them know. And if, depending on the schedule for town meeting, that might be a, rational place to do it. But if not, we'll do it a different way. And I think, is this the last slide, Shadera?
The next one's next steps.
Okay, next slide then. Okay.
Hey, Bruce, can I comment on your last slide?
Yes, please do. I'm sorry.
When you roll this out to hospital leaders to see the effect it has on their hospitals, I would highly encourage you to seek out the providers of care, i.e. primary care and other outside people, because without the providers providing care, this all goes to hell in a handbasket. And there is such a huge limited supply of providers of healthcare that you need to keep them engaged.
Right. No, I understood. I think that's and we'll raise that comment to our advisory group, many of whom are here, and to the Secretary of AHS. But you're right. The impacts on the providers in the community, are going to be there. And in fact, the ability of the community of physicians, advanced practice people, social workers, emergency medicine technicians, so forth and so on the ability to influence the hospital survival is going to be key to this too. So thank you for that. We'll try to figure a way to get that done. I think one of the well, you know, we'll work on it. Good point.
Thank you.
Page.
Remember, you were a provider once.
Yeah, until pretty recently. I've remember once at Geisinger, one of the cardiologists telling me I used to be a pretty good doc, but it's been a while. ID people provide 24-hour consultations, so and primary care. I used to do primary care for AIDS patients too, HIV positive. Okay, so next steps. We're gonna really push this engagement. We're on a short time frame. We're trying to get a lot of these things scheduled now. All of you, to the extent you can encourage your groups or groups in the community to participate, we would encourage that. And we have a lot of feedback with the Green Mountain with the Green Mountain Care Board folk. And if if possible, may need to come back to you all. Although I think your next meeting is scheduled for when, February or something. So that that may be a reasonable time. We are getting together materials, a lot of specific information, including the health needs assessments for the communities that exist. So that when we go to the hospitals, we can review all that. I think that's it. One last slide, which is our contact information, right, Shadera? Shadera?
Yeah, I see it.
Okay. So again, thank you very much for your input and your suggestions. We really appreciate it. We will take, we've been writing things down, the meeting's recorded. So we will go forth and try to get all this done. And if there are any further things that occur to you, whether you're having a bourbon tonight or whatever, or a beer, or you're in the shower tomorrow morning and you say, gee, I should have told them this, please send us an email. Because we are very much, although, a lot of prior experience, we are very much in a learning curve about all the very good things that you all in the state of Vermont are doing. You're, as you've said, very far advanced on a lot of this. And in fact, that's one of the other reasons for our great interest in this project. I've been reading and learning about a lot of what you've been doing, and I'm anxious to learn more. So again, thank you.
Thank you, Bruce and Elizabeth. And I will open it up for, we've had public comment throughout, but let me just open it up one more time. If there are questions for the OW team or for anyone at the board. This was so helpful. I took notes as well, so. You tired them out, Bruce. Oh, no, Walter.
I'm still going, Sue. What's the timeline for this? When do we?
Shadera, you want to show 9 so we can read?
Yeah, well, here you are. We're gonna this step 2 that we're currently embarked on. Getting out, doing the listening sessions, vetting things with the hospital, asking them a lot of operational questions, those sorts of things. We will complete by I'll say the middle of November, 15th of November. So we are urgently getting this done, and I have a lot of work to do by then. And then we're going to have Mathematica do the detailed analytics around the financials and the volumes and this and that. We are obligated by part of this to look at impacts on workforce. So that includes not only the traditional folks, physicians, advanced practice people, nurses, nursing techs, but also people that might otherwise be able to provide some care, pharmacists, EMTs, home health people, and others. Social workers. Many of these things, you had a manpower report done within the last year. That'll probably deal with most of that, but we need to examine the impacts and the trajectories of getting more providers in these various groups over the period of time that the hospitals have to survive until it happens. And then, as I said, beginning, early March, we will have scheduled and we'll come back around in person. So I have from where I live, about a 3-hour drive to Burlington, just as an example.
Well, I'm
Other
familiar
questions?
with Central Mass.
Well, I live in Princeton, just above
Oh,
Worcester.
yeah.
Yep.
Sir.
And thank you, Walter. Sharon?
Yeah, thanks. So there are other interested parties involved, not directly associated with the hospital, like you mentioned, transportation and community, and when you mentioned something about also how the hospitals swim in the ecosystem of healthcare. I think it's important to somehow pull out from Vermonters how they perceive their best care being delivered. Like we shouldn't assume that the hospital needs to do it all. And
Right.
maybe there are people in the community that wish to speak up that they really
Yeah.
like their particular primary care office. It's not hospital associated or physical therapy or something
Right.
totally, detached. If a hospital is swimming like a shark, we're in trouble.
Yeah.
We want to have that hospital be demonstrating how it actually looks into the communities that it serves, to see if there are other deliveries of the services, other affordable, efficient manner of doing the business of healthcare. I think that our evolution of how we perceive a hospital has changed from being brick and mortar to serve the sick and injured to being everything. A dispensary of pharmaceuticals, of medical equipment, of primary care, of physical therapy, of social services, of preventative medicine, of behavioral health, and what I'm getting at is any organization that's large has a bureaucratic cost with it. It just does. And generally higher salaries of those who run it. And I fear that this effort to look at the sustainability of a hospital or hospitals is not doing service to the whole ecosystem, whole healthcare system. If we so focus on keeping hospitals sustained at the cost of other healthcare entities that are doing a great job within the community, then we are not ahead. It will drive out patient choice and drive them to the most expensive care right now. There is no hospital that I know of in all of our nation that can deliver much of the healthcare services that aren't attached to acute care that are doing it more efficiently, affordably, with greater access, all of those delightful, sweet gems. So in this study going out into the community, somehow it's important to draft in the message that you seek to get information back from about how they perceive, they really wish to have their care be delivered. You know, if a mother is expecting, and does she really want to depend so much on a hospital? Does
Right.
she want to have a birthing center?
Right.
So, and we've already talked, I've heard you guys talk, everybody's been talking about other factors than what the hospital is about and delivered. But I don't know how the actual movement within the community is going to pull out the importance of the whole pool, the whole ocean, not
Yeah.
just
Well,
the sharks.
Well, I take your point, and you know, I think a key here is, as you've pointed out, you know, to me, hospitals are a place of last resort, right? I mean, it's where you go when everything else has failed. It's rescue care. One of the things that, you know, we've talked to the Green Mountain folks about is there are increasing options that are not limited just to birthing centers and other things. There are a lot of ways to deliver care at home. And other Medicaid agencies, other hospital systems do that. People can, you know, receive everything from chemotherapy to hemodialysis to respirator-related care at home if support systems exist, you know, and so forth. So absolutely agree with your point. We will, in formulating, in trying to get feedback from people and in formulating the options, look at those things and test their acceptability. And they will have enormous impacts on, quote, the sustainability of the hospital, right? I mean, there's a previous study that says 30%, up to 30% of visits of money billed for care in the emergency room and inpatient care would be preventable or avoidable by appropriate primary care or non-hospital services. And I think, truth be known, it's higher than that, right? So absolutely agree with what you're saying. And that's part of what we want to try to draw out of the conversations with all these other groups, right? It gets to the diverse populations, it gets to the, you know, pregnant ladies. You know, one issue that's arisen when you look at the some of the vital statistics and the sections on OB is that some HSAs have fairly high proportions of women who are not getting access to prenatal care until the 4th or 5th month. And that's way too late. Sir, another comment.
Sorry. I had a quick, that made me think of a group of providers that rarely gets mentioned, and particularly in Vermont, the naturopathic doctors. Okay. I'm seeing more and more patients that can't get into a primary care MD and are seeking out osteopathic or naturopathic doctors. And there are some extraordinarily competent and qualified naturopathic doctors in Vermont, and patients are getting their primary care done through them.
Okay, is there an organization of those folks? It's a good mention, and one I confess I had not thought of. So if you have a contact link, we'd love to have that.
I don't know of a group, but I know several of naturopathic physicians, and I can poll a couple of them and see if they have a resource.
Okay, or give them my email address.
Sure.
Thank you.
And in that line, you know, the people that are not under the umbrella of a hospital, they don't have payments nearly as much as a hospital gets. So in in trying to hire this limited pool of resources, we're now faced with an access problem as well. We can't get people into my business. My business never had a waiting list. It's over a month long. And what we hear when we go to hire somebody is our PTs are being offered $20,000 more. Ours is like in the 80,000s and theirs is triple digit. So in other words, there is a problem when we look to a hospital to do it all. When
Yeah,
that hospital has a
Yeah,
market
we're
share.
not looking to a hospital to do it all. I mean, you know,
Right.
we're
Okay.
not, but where our focus is on what the impacts of all this are on the hospital, right? That's what the legislature aimed us at. So,
Yeah, there's acts though that the Green Mountain Care Board have faced on pay parity that never got this attention. So it's all connected. What I'm saying is healthcare for the population is at the core of all we're talking about right now. And so we really not only need to look at the problem of hospitals having trouble, it's all of healthcare having trouble. And how can we get rid of the trouble? Not how do we just look at one part of it?
Yeah.
We really need to deep
Right.
dive into the whole system.
right, no, you're right. And as importantly, there's no help coming from anywhere else, right? Everybody's short of staff, everybody's short of money. You know, so some of it will likely be how do we rearrange and change what we're currently doing? But you're right, it's going to affect everybody, and we have to be thoughtful about that. But again, the Secretary of AHS reminded us Friday. There's a lot going on, and we're supposed to stay reasonably focused, but we will be in contact with these other groups and need to be thoughtful and aware of how these things affect everybody, right? I mean, because care starts with mom deciding to take the child to see the primary care doctor, and what happens if she can't get in?
One thing I'll
thank-
just add, go ahead.
No, go ahead, Elizabeth.
I was just going to say, I think thank you, the really good points that you're bringing up here. And one of the KPIs that we've shown here against the different value drivers will have different impacts, right? And so we're going to have to, as we select, or as you guys and as the board select different solutions, recommendations to move forward with, our intent is to provide visibility to the sort of trade-offs against that, right? When we think about hospital operations, viability, access, et cetera. All of those KPIs are not solely hospital focused. And so that will give us that pool or ocean perspective that we're getting at here so that we can make a decision or data-driven recommendations for what impacts could be expected by different kind of levers being pulled.
Thank you again, Chidera, Bruce, Elizabeth. Really, really great presentation. Thank you, members of the General Advisory and others here attending the meeting today. You see, that's great. All of the contact information, all of these slides were shared with the General Advisory. They're also on our website. There is also that link on our website if you want to sign up to get updates on the progress of our work and any of the meetings in the health service areas you're interested in hearing about, or all of them. So thank you very much. And we may be able to have an update at our next meeting if that works out with our OW folks. We'll take that back. But as a reminder, our next meeting is February 12th, 2024, followed by June 10th, 2024, and October 28th, 2024. Those all should be on your calendars And if you have any questions, just reach out to Kristen or to me. And I don't know if we have to adjourn this. It's there are 3 board members. I don't know, Laura, if you want to be on the safe side and we adjourn, we can.
Yeah,
it's
I
up to
think
you.
we hadn't before, but Owen did last time, so you
Sure.
may as well.
Sorry, I missed that. Do I need to make a motion to adjourn?
Yes, I think you need to make a motion to adjourn.
Oh, all right. Well, I move to adjourn.
I'll second.
All right. All those in favor, please say aye.
Yes.
Aye.
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 Thank you, everyone. Nice to see everyone, and thank you for the presentation today.
Thank you all. See you soon.
Thanks.